You're listening to Innovators, the podcast from Harris Search Associates, where we speak with global leaders in education, research, engineering, and the health sciences, and ask them to share lessons learned as they continue to advance the frontiers of innovation and discovery. Today's podcast will be led by Rick Skinner, Senior Consultant.
Today's podcast of Innovators comes as deaths from coronavirus, COVID-19, are forecast to kill more and more people around the world. As its speed increases in moving from contagion to illness and tragically for some to death, it may well make it difficult to think about the virus' impact on how best to prepare public health care professionals in the aftermath of this pandemic. And if COVID-19 and its effects are even now already so profound that changes are needed, who can be expected to be the agents of change? Fortunately, several public health school deans provided the kind of leadership needed and did so well in advance of COVID-19. One of those leaders is our guest today on Innovators. Already, many experts have found much about the world's and America's responses to the coronavirus to be lacking. Some have begun to sort out the logic of failure by reconstructing decisions and actions, which in hindsight were almost guaranteed to cause delay and confusion, contributing to more people's exposure, their affliction, and their death. After all, public officials at the time of the 1918 so-called Spanish flu pandemic denied and devalued the warnings of experts, even in the face of a disease that ultimately killed as many as 50 million people worldwide. Still, other analysts have identified steps taken at the time that advanced public health. Writing in the Journal of Preventive Medical Hygiene in March 2019, Martini and colleagues observed that the Spanish flu pandemic was the first official preventive actions were implemented in August 1918. And these included the obligatory notification of suspected cases and the surveillance of communities such as day schools, boarding schools, and barracks. Further, identifying suspected cases through surveillance and voluntary and/or mandatory quarantine or isolation enabled the spread of Spanish flu to be curbed. At that time, these public health measures were the only effective weapons against the disease, as no vaccines or antivirals were available. Virological and bacteriological analysis of preserved samples from infected soldiers and other young people who died during the pandemic period is a major step toward a better understanding of this pandemic and, I quote here, of how to prepare for future pandemics. But writing of the current crisis, Paul Keckley noted in a recent communication that COVID-19 placed healthcare into the spotlight, including the extraordinary dedication of frontline caregivers and the promise of new drugs and new vaccines. But the public's also been exposed to its challenges: pandemic preparedness, hospital capacity, and the complexity of global public health. It's a teachable moment for the system. What and how should education and preparation be changed so as to at least minimize the risk of a repeat of the COVID-19 pandemic? Who will lead that effort? For nearly a decade, Dr. Donna Peterson has pressed these and other questions on her faculty at the University of South Florida School of Public Health and her peers in academic public health. We are very fortunate to have her with us on Innovators. Dr. Peterson is professor and dean of the College of Public Health, as well as senior associate vice president of USF Health at the University of South Florida. In 2004, she came to USF from the University of Alabama at Birmingham, where she had served as associate and assistant dean of academic affairs and public health. But of special note for today is the leadership role Dr. Peterson has taken on in working to assure the relevance and the capability of public health graduates, not just at USF, but in the profession nationally and internationally. Most notable were her service as chair of the Association of Schools and Programs in Public Health's Framing the Future, a 4-year, very successful effort to reform the education and training of public health professionals, and her work as chair of the Public Health Leadership Institute. Welcome to Innovators, Dean Peterson.
Thank you, Dr. Skinner.
Is it possible, even at this early stage of COVID-19, and surely we are still early, to assess how this pandemic has affected the American public health system, and if you wish, other nation systems. What has the public health response revealed in terms of strengths and weaknesses of American public health? Has the American system of federalism, where the states have primary responsibility for actually implementing public health, and the federal government can or may choose to have a much more effective role or larger role, or choose instead to be somewhat on the sidelines? Do we know much yet about what the effects have been?
So I think this reveals many truths about public health and the system, and in particular, how the public understands what public health is and what it does. I think if there's any clear weakness, it's that we have not done a good job helping the public understand what public health is. I am a believer, I guess you would say. I actually like our system. I think it makes sense for states to bear responsibility for public health. It comes right out of the Constitution. In times like these, you may question that. But I think given the size of the nation, the diversity of the populations, the diversity of the capacity, and in fact, in this case, we're watching the virus spread in very interesting ways across different communities and across the nation, that it, to me, it makes sense, and I think just argues for stronger state public health systems. And again, what this reveals is over many years of very effective public health work to prevent diseases and protect the environment and promote health. It's easy for policymakers, decision makers, people who control the purse to say, well, everything's fine. We don't need to invest there. It's a very hard sell. It's always a hard sell to say, you really want to invest in something that we hope doesn't happen. By investing, you can help assure that it doesn't happen. And then when it doesn't happen, and people say, well, why did we invest in that? It didn't happen, right? So this is part of the challenge, which I think this really reveals, and it goes back to where I started. The public doesn't appreciate what public health is all about and what it does and how it works quietly, behind the scenes. You don't see it, protecting and promoting health every day.
Is there anything in this experience that says to you, not only what sources, but some form of understanding of the complexity of the American system could have forestalled some of this?
Well, yeah, and I think your point about what is the role at the national level, and clearly things like overarching preparedness, stockpiling, that kind of stuff makes sense. You don't want 50 states and territories having to do that. But again, we didn't do that very well either. I think it was very sad to hear that when stockpiles of equipment and materials were finally released, they had deteriorated such that they couldn't be used, which is, you can kind of shake your head and say, well, yeah, that was entirely predictable. But again, it goes back to why am I investing in something that might happen when I could be investing in things right now? And there are competing priorities for all of us, competing priorities in our society, and people that have to make decisions have tough decisions to make. So yeah, I think that does pose a challenge when you have 59 states and territories, each trying to respond to their own populations and their own particular needs, but can't possibly be prepared at the level that we needed to be prepared without the support of the feds.
One of the most striking aspects of COVID-19 has been how it thrust public health officials, nurses, medical officers, and the like, they get thrust into spokesperson roles. I must say we have been blessed with people like Anthony Fauci and so forth who have years, decades of experience in trying to deal with very complex questions that sometimes everyone wants simple answers, but there aren't simple answers. In the preparation and training of people for the field of public health, what role does communication play? Is it significant? And if so, how does one assess that before someone actually walks out and says, I'm a public health person?
Well, I think it's an excellent question. It's clearly a very vitally important skill set. And I don't think across the board we've done a particularly good job. When we rewrote helped rewrite the accreditation criteria. We included communication as a foundational skill. And we did that very, very intentionally. And we got a lot of pushback. And I think because how do I teach that? How do I assess it? You know, if they stand up in front of the classroom, you know, maybe they did a good job presenting something. How do I know they're going to be good in a crisis? How do I know they're good at risk communication? How do I know they can communicate to diverse audiences? Which is, I think, what the criteria asks for. You know, I'm one that believes that we have to be preparing our students with skills. That it's nice to have knowledge, and we want them to have basic knowledge, but they need skills. And they need skills that can be renewed and refreshed. They need a foundation on which they can build, and being able to effectively communicate has to be part of that skill set. Now, again, you know, the challenge is and you can see it almost from the very beginning, some students are very good. They're just good at speaking. They have a gift for it. Others are terrified. And we work with them at that level, but we also spend a lot of time talking about what is it you're trying to convey, and who are you trying to convey it to? And you have to think about, if you're trying to get funding from a foundation, that's different from speaking to a group of very angry and fearful parents at a school where there's been some kind of concern. It's very different to speak to the media. And we actually bring in people from the media, experts from the media. We bring in camera crews and the boom mics, and we put spotlights on them, and we have them with
spirits.
Right, and they're, you know, and we've actually just added this year, we actually filmed them so we could watch it again with them. Excellent. And, you know, so they can actually see themselves. And, you know, those are sometimes painful moments, but that's how we learn. And you can learn to have 3 points you want to make, and watch sports and watch what the interviewer asks and what the person asks. They don't answer the question. They make the point they want to make. And even though it feels really awkward to say, wow, that's a really good question, I want to talk about this. Those are good skills to have. So we try to build them, and we build them in a sequential scaffolding way. You know, we start at an introductory level, and we try to continue to add through the rest of their coursework. But it's absolutely a critical skill. And the last thing I would say is we try to teach our students, hey, it's okay if you're not good at something. Find people around you who are. And that's why we hire communications people, and that's why they're the ones that go in front of the camera.
Maybe Ebola taught us something, but one of the things that's striking about this is the role of social media. Because now you're communicating with an undifferentiated market who can just drop in whenever they want to. It strikes me that adds another level of complexity, because what it suggests is that much of the communication will be ad hoc. It will happen, and it may be ad-libbed because it's happening in real time. And in the age of streaming video, live video, it's even more the case that you will walk through that scrum of people, reporters who are sticking microphones into your face. It strikes me that is another level of complexity that previous generations didn't have to deal with as much.
No, that's completely true. And I think it brings up 2 points. And one is back to, if you are the communicator, the importance of clarity and consistency. And again, it doesn't matter what they're throwing at you. It doesn't matter, you know, in that instance, you know, you've got to be absolutely, positively clear, concise, and keep saying the same thing over and over again. And if you change your message because more data has appeared or you've learned more, say that. Say, you may have heard me.
Very interesting.
You know, you may have heard me last week, this week, you know, so that there's some continuity there. But
so it's the real time that once again imposes that necessity. And,
you know, and you can't, you know, and you know this, there are people who don't like to suggest that they were ever wrong. You know, it's not that I was wrong, it's that I was right at the time, but now I know something else, and so I need to re-inform and re-educate and try to make what I'm saying as clear as I possibly can. But the other reason it's challenging then is that our message has to somehow stand out from all of that other noise. Yes. And that's the challenge. And that's why, you know, like a bell in the village that rings over all the other sounds. That's what you have to be. You have to be that bell that is louder than everything else that people pay attention to. And that's
I have to confess, I didn't think about that, but you're absolutely right. The noise factor.
The noise factor.
Contemporary communications is how do you actually get through the noise? And in many cases, as I've suggested in another situation, if you Google coronavirus 19, you will come up with several hundreds of millions of hits, some of which are written by people who do not know what a coronavirus is. They're the same folks who buy the Corona beer instead. That leads me to something I think for me is a very clear outcome, at least at this early stage. The need for more public health officials. There's going to be an extraordinary, if we know anything else about when we've had tragedies, we know that almost immediately there will be both opportunities and demands for more and better people to come into the public health field. Now, I'm struck by the fact that until fairly recently, there was no undergraduate major in public health. You would not find that. You had to get a master's in public health. I know you have chosen to go into undergraduate education in public health. Is the notion behind that the master's, the MPH prepares you for a strategic role of some kind in public health, and the undergraduate PH program allows you to be one of those tactical people who gets things done? Is that a fair discussion, and is that a way in which we can address this tremendous demand that I see forthcoming?
It's been a very interesting discussion, and it began before the Framing the Future initiative started. And in fact, and I didn't know this, there are some universities that have had undergraduate public health programs for years.
Really?
For years. There were only a handful, and they were in very specific areas, environmental health,
okay.
Health administration, not necessarily broad public health. But what was happening, and this is around, I don't even know, I'm so bad with time, somewhere in the early 2000s, I think, we started noticing undergraduate public health programs popping up in sort of unlikely places, not in large research universities with academic centers, but in the private schools with the liberal arts bent. And so we started saying, what is that about? And when we started to explore it, and we did a survey, and again, I'm sorry that I'm so bad with remembering what year it was, but we did a survey, and at the time we found something like 140 undergraduate public health programs.
140?
That's what I recall, 130, 140. Yeah, and we were like, wow. And they weren't all called public health. They had interesting names, but they, it smells like public health. It's probably public health. And the organization of schools of public health, we got together and said, well, and we've been staunchly in the graduate, we are masters of public health, and some places doctors of public health, and absolutely PhDs and MS degrees, and we don't do undergraduate public health. But we got together and said, well, but do we have something to say about it? Do we care about it? And we decided, yes, we did. And the reason I give you this long preamble is that we spent a lot of time, and we continue to spend time, discussing, is an undergraduate degree in public health preparation for the workforce? Is an undergraduate degree in public health preparation for being a good member of the community, just for life? Or is an undergraduate public health degree really great preparation for other graduate or professional degree programs in health or other areas that impact health, like law and business and public administration, engineering, right? And we were sort of arguing about it, and then we decided it really didn't matter, that it's a good, it's like a common good for as many undergraduates as possible to be exposed to public health. So that's sort of one. So it's in schools of public health's best interest to offer at least a course in public health to undergrads, just for the purpose of, as we started this conversation, having more people out in the public and the community that know what public health is. And then from there, kind of like back to states have responsibility for public health, you know your community, you know what the need and the demand might be, you know what the student interest is, and you know what your capacity is, what is the talent in the faculty And then you figure out what makes sense for you. So when we designed what we called critical component elements, I think, because we didn't want to call them competencies and we didn't want to call them objectives, so we came up with the term. It was really to provide a framework for undergraduate public health education for any of those desired outcomes. So to answer one part of your question, yes, I know from my own experience that state health departments, and particularly the local public health departments, love to have bachelor's trained people in public health to be environmental specialists, disease outbreak surveillance staff to help.
And these are employers. These are employers.
As employees. They're always looking to hire talented people, and they love having this new pool of talented undergraduates to hire from. So that's sort of one answer to the question. The other answer to the question is that we are finding, and this isn't necessarily all across the board, but in some universities, the undergraduate public health major has become the pre-med degree. It has become the pharmacy degree. It has become the right? Because people recognize that students can get all those in a chemistry, molecular, they can take all the prereq classes, but when they come with a public health perspective, they bring this really interesting, right? They look at things in a So we're watching that happen. And then that should create space. And this was also a lot of discussion through the task force work and the accreditation revision work is, well, then where is the MPH in relation to these undergraduate programs? And I like how you said it. They're not competitors. The MPH should be someone more advanced in their career with more maturity to take a more leadership role, a systems role, a strategic role. And we know we need more of those people in the public health system. Badly we need. Badly, right? And I'm sure you know this, and this has been the case for many, many years, that most graduates of Masters of Public Health programs don't go into state and local health departments.
Precisely.
So we need to make those options somehow more attractive, and we need to help those agencies see that they can fill their entry-level positions, their, as you say, more tactical operations type people with undergraduates, and then bring in people with master's degrees into the management ranks, the higher level positions to provide that leadership that we need.
So has the debate over whether to be an undergrad, is it over? Is the debate over, or is this still something that's an issue?
I think it's pretty much over. I mean, when we got the report through, we got it adopted. The Council on Education for Public Health, which is the accrediting body, they went ahead and created standards for undergraduate programs that weren't part of schools and programs of public health. That was controversial at the time, but now I think people appreciate that we have, comprehensive, high quality programs. I still occasionally get this question, well, aren't undergrads, crowding out the master's students for jobs? And, I haven't seen it where I am. I have not, this idea that you would hire an undergrad because they're less expensive. My colleagues in public health in this state and in the region, frankly, find that insulting. I'm about getting the right people in the right jobs, and I need talent, and I need people who can lead.
Can I ask you a kind of follow-up question? Are the colleges and schools of public health in the United States ready to grow that number of students?
Yes, I would say for the most part, yes. I think, and I heard this when the task force was doing its work. I had the great privilege of traveling around the country and engaging people in the conversation. And I heard that there was capacity, that there were schools of public health that said, yeah, we could have more students in these classes. We could, we could bring in more. One of the limiting factors, and again, it depends on where you are geographically, but one of the limiting factors is the field placements.
That's what I was going to raise.
And so the accreditor actually addressed that head on by saying, we don't necessarily think every student needs a full-time, full-blown field experience.
The accrediting body said that.
The accrediting body. And the accrediting body absolutely set it at the undergrad level. They do not require it at the undergrad level. And at the graduate level, we sort of blew up the notion of a single full-time intensive field experience, which for some students in some programs is essential and is appropriate. But for others, what we said instead was, how about you make sure your students have a variety of practice-based experiences so that they not only get some depth of experience, but some breadth. And you figure out what makes sense, again, for your students and what they're looking for, your community and what it needs, your faculty, you make sense of that. And that lets you better accommodate people who are already employed in the field.
Gotcha.
Because that was always the challenge. Well, what, I have to quit my job and go do an internship someplace else? It allows students to explore, and they can do it over the entire course of their tenure with you. It's not like, okay, you're locked in this classroom and then we release you at the end and you go dive in somewhere. And for some students, they don't like where they end up. And then they're sort of turned off. That's okay. Well, that wasn't a good idea. So first semester, let's have you, even if it's, go to a county commission meeting and hear them debate, health insurance. Go to a nonprofit organization and spend some time on the weekends. There's lots of things you can do to get exposed to public health. Take your camera out and start taking pictures of what looks like public health to you and then reflect on it. And then you build from there. And in my college, we found this to be really, really nice. Students like the opportunities to get out and about, see different things. We bring in more speakers. We've come up with a program called Passports of Professionalism, so that in addition to them having their own practical experiences, they can go, they hear lectures, they go to, as I said, county commission meeting, things, and they get credit for that, and it really helps them understand what it means to be a public health professional, what it means to interact with different groups in the community, different sectors, and see.
So the question of the expected, what I think many of us expect to be a substantially larger demand for public health, we can do that then, is what it sounds like.
Yeah, I think there are some schools that turn them away now. There are others with capacity.
Okay, I think that's encouraging.
Yeah.
I think that's particularly encouraging because I do think the need is going to be somewhat immediate. We've known for years about, in an age where we have older people like myself who have chronic diseases and so forth and are going to need to be cared for. So, well, let me go on to another question that takes you probably a little bit out of your comfort zone. I don't know that you're an architect or an engineer, but I found myself asking this question. Even before COVID-19 came, it was commonplace to hear discussions that talked about how we got to get closed down all these hospitals because nobody's going to go to a hospital anymore and so forth. Well, about the same time that conversation took place, we suddenly discovered we needed far more ICUs and far more hospitals than we've ever needed before. So the question becomes, how, if you're going to prepare people for what could be, and now we have evidence that suggests the pandemics may not either, they're not going to go away.
Right.
How to best to prepare to deal with pandemics that is in some way partakes of technology, partakes of the idea of neighborhood sites in which there are multiple services available that include social services as well as public health. What's the future hold in terms of how we're going to respond in the future if we're going to be able to respond to what we've seen in this pandemic?
So as you know, that's a very complicated question.
I was hoping you had a very simple answer.
The answer is yes. Because what you're raising is, a number of different approaches, different sectors, different responsibilities. So we have healthcare, which in this country we have very successfully divorced from all other social services.
Exactly.
It's a clear problem. Healthcare, as it has evolved, as you say, people were talking about hospitals as the last holdout of a dying, age of healthcare. But boy, when you need one, you need one. And you need it close at hand. How healthcare is delivered, I think what this pandemic has certainly shown us in my community is that telehealth is absolutely viable. Patients like it. Healthcare providers seem to be adapting to it. There's reimbursement for it. And I think that's something that a lot of us have been advocating for years. It doesn't work for everything, but for a lot of issues that people have, telehealth can be a great way to provide continuity of care that's more accessible, more efficient. And with technology, we can monitor many of the signals and signs of the chronic diseases that you mentioned. That can all be entered in a database. People have access to their own records now. That wasn't something that was true in the past. And so I think we're getting more to a shared sort of responsibility for health and health care with patients and providers and community resources sort of coming together. So I think I would like to hope we see more of an integrated horizontal approach to what it is that makes people healthy. And it's not just health care. And when we think about all the social determinants of health, we can't leave healthcare out of that, but they also, they can't be above it or extant from it. I mean, we have to really be thinking about where do people live and where do they work and what's their environment like and what kind of educational opportunities do they have and how safe is it where they live and what access do they have to food and water and clean air and all those things. And healthcare providers need to, not that they don't, I mean, they do appreciate those things, but somehow we have to find a way to share in that responsibility. And, healthcare is something you need when you need it. I'd like to think we get to a place after this where everyone has financial access to healthcare, that's just understood, that's necessary. I hope we're there. I was on a talk show the other day where we were talking about, you would hate to think that someone's concern about a medical bill they couldn't pay keeps them from going in and getting tested. That's exactly what you don't want. You want people that can't be the barrier. It has to be just part and parcel of how the system works.
And that in itself, it would be a major social change for the United States.
That would be a huge social change. But then the whole system would have to adapt to that. And as you say, there's probably different ways to structure and organize and finance and evaluate health care along a continuum and in some way connect in some kind of hub and spoke kind of way maybe. Because you do need, as we said, when you need an ICU bed, you need an ICU bed. There's no
substitute.
Telehealth. There's no community. There's no home-based ICU. So we have to figure this out. But I would like to think we figure it out in a more holistic, collective kind of way than every system coming up with its own schema. But I don't know. I mean, it'll be interesting to see.
Dean Peterson, you have been known now for probably the better part of a decade or more as someone who has pushed the whole field of academic public health. You have been an agent for change. If we need to change, and your candor with which you spoke about communications and the like, suggests that you think there's still work to be done, perfecting, if you will, how we prepare people to be public health workers. Who's going to do that work? I don't know of many deans of any kind that have big holes in their schedules that they can take out to do work in curriculum reform and the like. What are going to be the instigators of change other than Donna Peterson and a few other rabble-rousers that she knows? Who's going to make this change and how long will it take?
Well, I first want to say that it's not just me and a few. When we formed the Framing the Future Task Force, there were a lot of people who stepped up immediately. And you can't do work like this exclusively within the academic world. You have to engage the larger community. So and I don't remember exactly how many, but the original task force had academic public health leaders. It had leaders from the CDC and the government and state and local health department organizations, fun.
If I may interrupt just for a moment, I talked to someone who was part of that, and she said there were so many people you had to have numbers on your back to know who everyone was. So I think that was a bit apocryphal, but in any event,
Well, no, the
yes.
point is it started smallish. I mean, we had a reasonably sized, when you create a task force, it's usually small and agile, right? But then people started calling when they heard about it and said, well, I want to be a part of that. And there was never a good reason to say no. So we just said yes. So by the end, I think we had 58 people. So now it's no longer.
Be careful for what you ask for.
It's no longer a task force. But the point is, people will step up. They will find time because they know how important it is. Yep. And the educational piece is only one piece. We have to find people and capture their imaginations and get them to join us and provide the best training we can, but then they have to go out into a field that is always evolving and adapting as well. And we all need to be agents of change. This isn't a one sector role. I mean, we all have to do this together. And that's how we did the whole Framing the Future effort. When I went around the country, I was not only invited by schools and programs of public health, I was invited by state public health associations. I was invited by state health departments. I was, because people wanted to be part of the conversation. I think it's safe to say that we are never done. We can never say, okay, close the book, go out for a walk. There's always, because the world changes, things happen. We have new experiences, we have new challenges, we have new capacities. And we need to be constantly adapting to that and working hopefully in anticipation, not just in a reactive way, but anticipating what's to come. So the good news is the Association of Schools and Programs of Public Health was actually about to launch Framing the Future 2.0. They've postponed the inaugural meeting with everything going on, but they are convening another.
They're ready.
Because it's been 5 years. And it's time to re-examine and refresh and re-envision and see where we are, see what worked, what didn't work. How has the accreditation criteria helped propel innovation? Or has it actually hindered it in some way? We don't know. We need to examine that. And then, continue to talk to all of the constituents that we serve. We need to know what, and I think now there's going to be a lot more people interested in that conversation. So. Yes. There's always good work to be done, and we're never done. And your remarks are very kind, but I am not alone. There's lots of people out there that are willing to step up and make this happen, because it's just critical. This isn't something we do, because we love learning or we're interested. I mean, this is something we do because our lives depend on it. The planet depends on it.
Good way of putting it, and I want to thank you again. It strikes me that amongst your other duties, you serve as kind of a conscience for a field that seems to be very self-conscious about being relevant, being timely, and being effective. Dr. Peterson, thank you very, very much for your time. Thank you for the work you do, and thank you for being on Innovators.
Thank you. It was a pleasure. Appreciate it.
Thank you for listening to Innovators, a production of Harris Search Associates. We'll have more insightful conversations with global thought leaders to follow.